two excellent plenary talks. Marian Knight is Professor of Maternal and Child Population Health. I think she's well known to most of us, but has had some really interesting insight into the COVID impact, and we've asked her to talk about hypertension and COVID. So without anything more, I'm going to just invite Marian to talk to us. If there is time to ask questions, we will at the end. If not, I'm sure Marian will be delighted to go to the question and answer function. Thank you, Marian.
Thank you very much, Andy. Hopefully you can see my slides now. I'm very honoured to be able to speak at APEC, and I hope not. Some of this will be new to those of you who've obviously been all too familiar with COVID and what's been happening. Interesting reflection on the absolute explosion of information we've had between December last year, where obviously there were emerging information, no data on pregnancy, to March, when we had the first case series published from Wuhan, 9 pregnant women, none severely ill, all had cesarean births, which set an interesting precedent. Babies were all well. As of June, more than 500 publications, so less than 3 months later, many additional preprints, mostly small case series or hospital series, and many were overlapping. So it's perhaps difficult to interpret some of those. And the UK national data were published first in June, thanks to many of you, I'm sure, who will be listening. I did a quick search on PubMed last week. Now more than 1,500 publications. Really difficult to work out where we are with making head nor tail of the reliability of the pregnancy information. So I guess I just would signpost you towards the WHO Living Systematic Review, which is the WHO Collaborating Centre in Birmingham are leading, and also the collection that Jim Thornton and his colleagues have been pulling together to look at the different pregnancy studies. So I said I'd focused on hypertension and COVID-19, so I had to do a little bit of literature reviewing myself to look at where we were in terms of the non-pregnant population and evidence on hypertension. And this was very much my assumption coming into looking at the literature. What is already known box from the hospital data, UK hospital data, which were published back in May, which was very firm in their assumption that older male adults, people with diabetes, hypertension, cardiovascular disease, or chronic respiratory disease are at greater risk of severe COVID-19. However, I then came on to look at more recent data, and I have focused for this talk on UK data. And this is on the left, the later publication from the same group who had published that national hospital data in May, their publication from September, and a publication from a group who use GP data, which was published in October. Both of these set out to look at risk stratification, a way of predicting risk amongst people admitted to hospital. And the first one generated what they call the 4C mortality score. The second one generated the Q-COVID risk score. And interestingly, neither include hypertension amongst the factors associated with risk, although clearly they do have other comorbidities. Sadly, looking at both of them, the first one doesn't mention pregnancy. The second one, if you look at the in the small print, as it were, it says that there were insufficient numbers of pregnant women in their data set to be able to assess whether pregnancy was a risk of admission or mortality. So just to remind everybody, and as I said, again, I'm really, I know many of you have contributed to the study. We were able to start national surveillance of women who were admitted to hospital with COVID-19 in pregnancy through UKOSS very quickly, because the system was there and in place. And in fact, because we had a study that was already hibernated and ready to go. In fact, had a 9-year gestation as opposed to a 9-month gestation, having started life as a follow-up to the H1N1 pandemic in 2009, when they recognized that there was a need for such hibernated studies. And in fact, it's one of 8 studies that were activated rapidly for SARS-CoV-2. So the data from March and the first half of April, we identified 427 pregnant women admitted to hospital with SARS-CoV-2 infection, and that's about 5 per 1,000 giving birth. We've now got information on more than 2,000 women. By and large, the patterns I'm showing you now have not changed dramatically across the time of the pandemic. So I'm here to be focusing on hypertension. But this just shows the characteristics of those 427 women. Key things you will see that are, and certainly did make the headlines, is the very high proportion of women from Black or other minority ethnic groups. And this reflects the inequalities or the disparities in outcomes between Black and other minority ethnic women that you will be all too familiar with from the Embrace data. Women with pre-existing medical problems are definitely overrepresented amongst this group of women admitted to hospital. And looking just at chronic hypertension on its own, 3% of women admitted to hospital had chronic hypertension. And when you compare that with a control group of pregnant women identified also through other UKOSS studies, you can see that women with hypertension were certainly overrepresented amongst the women admitted. Thinking again about hypertension, is hypertension associated with severity of COVID-19? And here I've just divided that group of women up into those who were admitted to intensive care and those who were not admitted to intensive care. You can see the numbers are small, so it's difficult here to know whether this is a true increase in severity amongst women with hypertension, about a doubling of the odds of ICU admission amongst women with hypertension. So I mentioned earlier my go-to source for more robust information is the WHO Living Systematic Review, and these are their results that were published in the BMJ in August now. And you can see that 2 other studies have actually reported remarkably consistently similar findings associating hypertension, chronic hypertension amongst pregnant women with severe outcomes of COVID-19. So again, about a doubling of the odds. This, unfortunately, with hypertension, I have no national denominator information which can allow me to provide you with absolute rates and rate ratios like these. But you can see that the inequalities in incidence amongst different population groups. So older women have a higher odds of a higher risk of admission more overweight and obese women have a higher odds of admission, as do women from Black and minority ethnic groups. These outcome data I've updated with the most recent pregnancy outcome data we have now. So we now have outcomes for all of the women in terms of hospital discharge, critical care or mortality. And we have pregnancy outcomes for 94% of the women. So looking at the women who were admitted, about 10% had critical care, 1% had ECMO, a quarter had SARS-CoV-2 pneumonia on imaging, and of this cohort, 5 women died. The vast majority of women were discharged well. And that maternal mortality rate that you'll have seen before was about 6 in every 100,000 women. So maternal death from COVID-19 is rare. A question that we are perhaps still struggling with is whether pregnant women are more severely affected by COVID-19 than non-pregnant women of reproductive age. These results from the first analysis of hospital patients in the UK actually suggested that there was no difference in outcomes. Looking at the outcomes of women of reproductive age who were not pregnant, they're very similar, if not worse, than the outcomes for women who were pregnant with COVID-19. But perhaps more recent data does suggest that there may be an increase in the proportion of pregnant women who are currently in the current wave who have COVID-19 who are receiving critical care. It's very difficult to know whether this is due to pregnant women having more severe illness, whether it is due to pregnant women potentially not the severity of their illness not getting recognized as early as it might be, or whether it is simply a reflection of the fact that they are now able to access critical care because capacity is not as strained as it was. But nevertheless, it is something that we do need to clearly recognize. So some of you may know, APEC is obviously close to my heart. I started my research career as a PhD student with Chris Redman. So I have to get some spiral arteries and some thinking about pre-eclampsia onto my slides in some way. And one of the concerns about COVID-19 and potentially about women who were infected with COVID-19 early in pregnancy is the potential association with later complications and later placental complications, of which pre-eclampsia might be one. And you can see from this cohort that 20% of women had COVID-19 in the second trimester or earlier. As I said, we've now followed up 94% of women, and reassuringly, you can see at the bottom of the slide, amongst this cohort of women, pre-eclampsia does not appear to be, they don't appear to have a higher rate of pre-eclampsia than a cohort that's not had infection with COVID-19. So that's reassuring information. You will see overall that for babies, so 20% of women had a preterm birth. 6% of preterm births were spontaneous. The remainder were largely due to maternal indications for COVID-19. And you can see that more than half of women had a cesarean birth, but a relatively small proportion of those were actually due to COVID-19. And by and large, infant outcomes were and are good. Very few babies have a confirmed infection, and hopefully you will all have seen the paper that was published at the very beginning of this week, showing that overall in March and April, across the whole of the UK, there were only 66 neonates who received inpatient care in the UK with SARS-CoV-2 infection. Of those babies, there were only 2 possible cases of early transmission of infection from the mother, and of those 66 babies, only 17 had a mother who was confirmed to have SARS-CoV-2 infection at birth. So this really adds support to the guidance that has been in place in the UK, and is certainly the position of the WHO to keep mum and baby together as far as possible when mum has confirmed SARS-CoV-2 infection, and also to support women who choose to breastfeed. I'd be failing in my duty if I didn't talk a little bit about Embrace, and as many of you will know, we did a rapid inquiry which a number of you also helped with, into the care of the women who died during March, April and May with SARS-CoV-2 infection, but also those who died by suicide over that period or as a result of domestic violence. And I just want to give you sort of 4 key headlines that we do need to remember in this second wave, second lockdown for those of us who are in England. It's really important that we continue to recognise when pregnant women are unwell. So this woman was admitted with a respiratory rate of 36. This was attributed to hyperventilation. She was not seen by an obstetrician for 11 hours after admission, and all the decisions as a consequence were made very late. So it really emphasises the importance of multidisciplinary care, making sure that we have the whole team, obstetricians, midwives, physicians, anaesthetists involved in the care of these women. We clearly need to get our communication right. There was certainly evidence that women were presenting to hospital late, either because they were reluctant to attend or for fear of infection. And we do still need to make sure that women know what symptoms are concerning and when to present to their hospital. In terms of mental health, the main theme is that women were, in many places, face-to-face perinatal mental health care was withdrawn, and women were presenting with symptoms repeatedly, but they were not necessarily receiving the mental health care they needed. So if you are caring for women who are presenting repeatedly with mental health problems, do consider that a red flag that means they do need a review, and with a consideration of face-to-face review. And the final thing to emphasize from this is the importance of ongoing safeguarding, and that we need to make sure that women can be taken to a place of safety should they need it. So just to summarise, the evidence suggests that certainly in pregnancy, pre-existing hypertension does seem to be associated with both admission with SARS-CoV-2 in pregnancy and severity of infection. The hospitalised women are mostly in the late 2nd and 3rd trimester, and it doesn't look from the data we have as if there's evidence of an increase in pre-eclampsia, which is reassuring. very little evidence of viral transmission to the infant. So let's keep mums and babies together, and let's continue to encourage breastfeeding. We do need to remember the multidisciplinary team, that making sure that women know when to seek help, and provision of mental health services and ensuring safeguarding. Lots of people to thank, not just those of you who've helped provide data, but also obviously funders for these studies. Thank you very much.
Thanks very much, Marian. And I've just invite people to ask questions on the question and answer function. There aren't any at the moment, but it sounds very reassuring generally. A sort of question for you, I guess, is do you think these reports that there may be some impact in pregnancy with bigger numbers are likely, or is this kind of reporting bias? Because that's obviously what everyone's concerned about. So
in terms of intensive care admission, so I guess my reflection is from the Embrace data. There was no doubt that with pregnant women, the severity of their illness was not necessarily recognised as early as it would have been if they were not pregnant. So I guess I don't know whether the overrepresentation, the potential overrepresentation of women in intensive care, of pregnant women in intensive care, is because the severity of their illness is not being recognised as early as it might be, or whether they are genuinely more severely ill. I can't tell you the answer to those. The one thing I know we can change is to make sure we can recognise their illness earlier and make sure they know to present earlier. So I guess those are going to be my key messages, and that's why emphasising the multidisciplinary involvement, both obstetrics and physicians and anaesthetics in caring for pregnant women with COVID, to make sure that the severity of their illness is recognised, is really important.
Okay, great, thanks, Marian. We don't seem to have. We got a question here from Kathy Nelson-Piercy. Could it be because we have lower thresholds to admit pregnant women to ICU?
A very good question, Kathy, and certainly a possibility. And in fact, I mean, I do feel that is probably, so the US data suggest a much higher proportion of women admitted to intensive care, and I do think that is a factor in the States. It is possible it might be that here. The other issue is that actually there might have been lower thresholds for admitting pregnant women in the first wave. So it may be that now we do have the capacity, we are able to admit pregnant women to intensive care. And, you know, I'm certainly not saying that we shouldn't be admitting women to intensive care when they need it.
Yeah. All right, Marian, thank you. I mean, we'll keep to time, and thank you very much for sharing the up-to-date data, and it's very reassuring, and please keep up the good work, because I think you've done a phenomenal job kind of sort of leading the world on some good evidence of pregnancy, and we're keeping a close eye on it, so we're all very grateful.